Okay, so good day everyone. So for day class, we will be discussing about individual dosing naman tayo ngayon. Okay, so before class, we were discussing about the general way of computing for IV push, IV infusion. Now this time on class, we'll be discussing individual drugs. Okay, so alam naman natin class that individual drugs have different needs. Okay, they have different effects. So therefore, we have to individualize our treatment. Okay, for each drug. Okay, to cater it to our patients. Okay, alam naman natin class that there are certain drugs that requires attention. Okay, and these drugs are normally categorized under the high-risk medications, okay, high-alert medications, or these are drugs class with narrow therapeutic window. So we will, throughout the course class, we will be discussing only a few, okay, which are a few drugs with narrow therapeutic windows. For the purpose class na, i-discuss lang natin yung madalas na gamitin sa hospital. Okay? And one of those drugs, of course, would be aminoglycosides. It's a widely used medication to treat infections, specifically class gram-negative types of infections. Right? Yeah. So, due to time constraint, you only have pharmacokinetics, clinical pharmacokinetics for one semester. Okay, so i-condense natin yung mga pwede natin i-discuss. Right? And again, class, our topic for today will be about aminoglycosides. Now, for the objectives of this lecture, at the end of the lecture, students should be able to first know when to use aminoglycosides, okay, so that we can validate the use of aminoglycosides. Alam niyo naman class, in the hospitals, we try to regulate the use of certain antibiotics to prevent the emergence of resistance, antimicrobial resistance. Okay, second, to understand how aminoglycosides are dosed based on age, weight, conditions, etc. Third is to be able to design a pharmacokinetic dosing regimen based on patient factors, okay, such as may kidney failure ba ang patient ko, weight, age, okay, stuff like that, and various pharmacokinetic parameters. And lastly, class, to appreciate the importance of individualized dosing of aminoglycosides on different types of population. So first and foremost, class, what is an aminoglycoside? So basically, class, aminoglycosides, actually, alam nyo na to. Okay, you've already had this discussion in organic medicinals, right? Probably sa pharmacology din. Okay, so what we know about aminoglycoside class would be, or sa microbiology pala, okay, is that it's an antibiotic mostly used for gram-negative bacteria, and it's the drug of choice for anaerobic gram-negative bacteria. And the thing, class, with aminoglycoside is that it's a dose-dependent killer. Okay, dependent. Tanggalin nyo yung hindi na yan. Okay, that's a dose-dependent killing. Ibig sabihin, class, the higher the concentration used, higher yung kill rate ng aminoglycosides. Kasi class, there are two types of antibiotics. We have the dose-dependent antibiotics and the time-dependent antibiotics. For dose-dependent class, that includes aminoglycosides, vancomycin, so on and so forth. Time-dependent killers naman class includes penicillins. Okay? Amoxicillin, ganyan-ganyan. So meaning class, when you're trying to kill a bacteria using a time-dependent antibiotic, okay, even if you use it at a low dose, carry lang. Kasi class, the way this antibiotic kills is, it depends on how long the bacteria is exposed to the antibiotic. Okay, kaya nga class, usually, di ba, pag nagbibigay tayo ng penicillins, we always say complete 7-day regimen. Okay, kahit mababa ang dose, carry lang yon. For the reason, class, na ang penicillin, okay, they kill via time-dependent killing mechanisms. So meaning, the longer a bacteria is exposed to penicillin, okay, mas nagagawa ng penicillin na kanyang trabaho. Unlike class with aminoglycosides, it's a dose-dependent killer. Meaning, as long as the concentration is high, siguradong madededs yung antibiotic. Kahit na 3 days lang ang treatment, basta mataas ang concentration ng gamot, mamamatay yung bacteria. Right? So that's why it's a dose-dependent killing. And you'll realize, class, mamaya-maya, kung because of this dose-dependent killing capacity of our aminoglycosides, okay, may specific tayong way to adjust doses, okay, with the use of aminoglycosides. Alright? So, yun. So, very much important sa kanya, class, is mataas lagi yung kanyang dose. Now, it's poorly absorbed following oral route. Okay, that's why most aminoglycosides are given intravenously. And IV route should be via infusion. Okay, and should not be given as push. I know some of our examples during the midterms, okay, would be, bibigyan ko ng example na pinupush yung aminoglycosides. Pero class, in reality, we rarely, actually, we don't give aminoglycosides as push as much as possible. Okay, for the reason class, it can cause extravasation. Ano ba yung extravasation na yan? Extravasation class is a phenomenon wherein, actually, it's not a phenomenon. Okay, ang nangyayari yan class is namamaga yung ugat kung saan mo in-administer yung gamot. Okay, aminoglycosides kasi class tend to be too potent. Okay, it's too concentrated wherein if na-expose by a push ang ating ugat, ang mangyayari class is pwedeng mag-leak out yung aminoglycosides at magsusugat-sugat yung IV site. Well, it would start off as swelling muna, redness, okay, then of course pain, and then worst comes to worst class, nagde-necrotize yung tissue surrounding the IV site. And that's one thing we try to avoid. Okay? Kaya class, normally when you give aminoglycosides, we give it via IV push. How long? Well, the usual class would be, of course, 1 hour in IV infusion. Right, so infusion for 1 hour. Okay? So, yan. The thing class with aminoglycoside is that it can cause ototoxicity and renal dysfunction. So, it's it's nephrotoxic. At the same time, it's ototoxic. It must be used with caution for patients with renal failure. Hence, class, one of the major things that we have to consider when adjusting the dose of aminoglycoside is the kidney function of our patient. Is it still good or not? Okay. And how do we measure, class, the kidney function of our patient? Well, normally we use the creatinine clearance or the glomerular filtration rate. Now, normally, class, we stage yung kidney problem ng isang patient using the creatinine clearance of our patient or the GFR, glomerular filtration rate. So if it's greater than 90, then stage 1 lang yun. Okay. Stage 2 would be between 60 to 89. Alright, that's ml per minute. Okay, then stage 3 would be 30 to 59 and so on and so forth. Alright. Now, sir, if you notice, okay, or if you notice class, greater than 90, pwede na. Okay pa yung kidney mo. So, sir, wala bang problema pag sobrang taas naman ng aking filtration rate? Okay, actually may problema din yun. Usually, pag greater than 120 ml per minute class ang yung glomerular filtration rate, meron namang tinatawag na condition na hyperfiltration. Okay, wherein sobra naman magtrabaho yung kidneys mo. Okay? And you don't want that naman to happen din. Okay, there are complications with hyperfiltration, conditions involving hyperfiltration. So you just want to get the sweet spot. Normally, just greater than 90, okay na yun. Okay, but not more than 120, more or less. Okay? Now, how do we assess kidney function? Okay, there are two ways, class, wherein we can assess kidney function. We have the Cockcroft and Gault equation, which is the oldest, okay, and the most widely used. And then we have the modified diet and renal disease equation, or the MDRD equation. Okay, let's call class Cockcroft and Gault as CGEQ. Tapos si modified diet, MDRD. Right? Now, the formula, class, for Cockcroft and Gault is something that is something that everybody knows na. Okay, creatinine clearance will just be multiplied to your weight. Pwede rin ideal body weight or adjusted body weight, depende. Kung female ang patient, multiply mo ba yun by 0.85? Okay, the reason for that, class, is yung 0.85 na to, okay, is because the female have less muscles as compared to male. And everybody knows, class, that creatinine is a muscle byproduct. Okay, muscle breakdown byproduct, sorry. Okay, it's a muscle breakdown byproduct. So therefore, class, the more muscles you have, such as us, male, okay, mas marami kami napuproduce na creatinine as compared to our female counterparts. Okay? Kaya normally, class, i-multiply mo yung creatinine clearance ng lalaki. If you're doing that for a female, you have to multiply it by 0.85 pa to reduce further the resulting creatinine clearance. Okay? Kasi mas konti ang serum creatinine usually ng babae kaysa lalaki. Then that's 140 minus age, this is in years, divided by 72 times serum creatinine. Okay, and serum creatinine, class, is usually in milligrams per deciliter. Now, in the hospital setting, class, computed na to para sa inyo. Alright, normally we don't compute this anymore separately, given na to sa atin ng ating mga medtech. Okay, because class, they just input it in a software, the software does it for them, the computation for them. Okay, so hindi natin kailangan magpakahirap. Pero again, it's still nice to know how to do the computation. Now, for the MDRD naman, class, that's 175 times creatinine, serum creatinine, raised to negative 1.154 times age, raised to negative 0.203. Now, if the patient is of African American descent, the GFR should be multiplied by 1.212 because African people daw tend to be larger in build. Okay, mas marami silang muscles. Right? And then, if female naman, multiply by 0.742. Now, my question usually sa akin dito is, sir, what if the patient is of African descent and babae siya? Okay, kung ganun ang situation, class, go for the times 0.742. Dito tayo. Automatic yan. Kasi babae yung patient natin. Okay, we all know, class, that what makes our muscles, or what triggers the growth of our muscles is testosterone. Okay, most females have low levels of testosterone as compared to males. Yung mga bodybuilders na babae, usually, gumagamit sila ng exogenous sources of testosterone to bulk up their muscles. Okay? So, yun. Now, the question comes into play, which equation or which renal assessment is better? Okay, is it the MDRD or the CGEQ? Now, of course, that usually depends on the situation. Okay, both naman kasi is used to estimate GFR and are easy to use. Okay, CGEQ, very established na. Kumbaga matagal na kasi ginagamit yung CGEQ. MDRD, kailan lang naman to nauso. I think it was in 2008, 2007, I'm not sure. Okay, pero recent, hindi naman siya ganun ka-recent, pero mas recent siya as compared to CGEQ. Now, MDRD class usually best use, okay, when yung ang technique na ginamit o yung assay na ginamit to check for serum creatinine is yung the new global serum creatinine assay standard. Okay? Kumbaga, bago-bago yung assay procedure na ginagamit to assess the creatinine, the serum creatinine. Okay? So, maganda yung MDRD doon. Kasi kumbaga, MDRD was established to coincide with the newer assay procedures. CGEQ kasi is based on older assay procedures. However, the CGEQ class can better predict age-related declines in renal function. Kasi if you notice, class, with MDRD, okay, although given din naman yung age dyan, pero it's not as robust as how Cockcroft and Goat equation does this. Okay, kaya normally, class, kung ang patient natin is elderly, kadalasan ginagamit is CGEQ na lang. Okay, most of the time. Okay, as compared to MDRD. Pero again, it's debatable. Okay, debatable pa rin naman yan. Pero normally, ginagamit pa rin CGEQ. Now, here's the thing, class, normally in a hospital setting, okay, ang gamit pa rin natin is CGEQ. Why? Kasi most manufacturers, class, whenever they create a dosing regimen, a dosing table, okay, naka-base yun, class, sa CGEQ. Alright? Not unless, class, yung manufacturers gumawa ng bagong clinical study, okay, wherein MDRD ang ginamit nila, okay, malamang sa malamang, class, ang gagamitin pa rin nila is CGEQ. Okay? Usually, ang CGEQ class is, kasi nga, mas validated, mas well-established, matagal nang ginagamit, so, nakaugalian na, kumbaga. Okay, but I'm not saying, class, walang, hindi nagagamit ang MDRD. It's still being used. Okay, normally, class, ang MDRD ginagamit pa for patients with low GFR. So, meaning, kadalasan, gagamitin, class, ang MDRD kung alam kung may problema talaga ang kidneys ng patient. Okay, if the patient has kidney problems, then it's better to use MDRD. CGEQ, on the other hand, class, madalas na ginagamit yan if a patient is healthy. Okay? Mas most useful yan for dose adjustment if the patient's kidney problem is okay. Wala siyang kidney problem, sorry. Walang kidney problem, class, ang patient, mas maganda gamitin ang CGEQ or generally healthy. And normally, ang manufacturer, pag nagki-clinical trials, especially phase 1, ano bang gamit din ng patient? They usually use healthy patients. Okay? Kaya CGEQ ang madalas na ginagamit nila. Okay? Kaya yung dosing adjustment is based on CGEQ din. Now, some considerations when using the CGEQ. Okay? For MDRD, wala masyadong problema dyan eh. Pero for CGEQ class, okay? Usog natin yung ating natatakpan pala. Okay, when we're using CGEQ class, normally we use the ideal body weight or the adjusted body weight in the formula and no further BSA adjustment is needed. Okay, now, bakit ideal body weight? Okay, kasi class, normally the ideal body weight tends to measure lean mass. Lean mass, meaning mostly in-isolate niya yung muscle mass mo. Pag nag-ideal body weight ka. Kumbaga, less ang fats. Okay? Kasi if we use your actual body weight, say for example, if my actual body weight is, kunwari lang naman 70 kilograms. Yung 70 kilograms na yan, marami dyan siguro fat, right? Now, if you're using ideal body weight, ang kinukonsider din kasi nun, okay, ina-estimate lang nun is yung lean body weight mo. Right? The ideal body weight tries to measure your muscle mass lang as much as possible. Okay? Now, what about adjust kaya yun naman sa ginagamit when we're computing for CGEQ. Okay, ideal body weight. Alright? Kasi nga, ang mini-measure lang dito is yung creatinine. Okay? So, hindi na kailangan i-consider pa yung weight ng fat. Okay? And so on and so forth. Now, adjusted body weight naman class is usually done for obese patients. Okay, sobra-sobra naman yung fats nila. So, we use adjusted body weight. Okay? Now, normally kasi class 1 ml of 1 unit in CGEQ is equivalent to 1 unit in GFR. So, 1:1 na ang ratio. Okay? So, yun ang kinagandahan nun. Now, some other considerations. So, most drug manufacturers address dosing adjustment based on CGEQ. Now, if serum creatinine is derived using the newer methods for serum creatinine determination, then class we use the MDRD. However, if you use the CGEQ, okay, ang mangyayari is it will give a slightly higher creatinine clearance. Okay. Now, what about using MDRD? So, the MDRD equations are predictors of GFR, not creatinine clearance. Okay, so MDRD was validated using patients with CKD and may not be as accurate as CGEQ. Kasi sa CGEQ class, included ang mga healthy individuals. Nung ginawa ang MDRD, na-validate siya using patients with kidney problems na talaga. Okay, with kidney problems na. So, the thing lang class with MDRD is it's more easy to use because patients' height and weight is not required in the formula, only the age. However, there is no useful conversion factor to convert MDRD and CGEQ. So, ibig sabihin, if you use MDRD for that patient, tuloy-tuloy mo na yan hanggang dulo. Kasi walang conversion between MDRD and CGEQ. Okay? Now, we'll discuss class in a while nga pala how to compute for ideal body weight and adjusted body weight. Alright? Now, let's discuss this time how do we dose aminoglycosides. Let us start class with adults. Okay? Adults with relatively okay kidney functions. Right? Relative lang. Right? So these are 18 years old and above. So why do we have to individualize the dosing for aminoglycosides? Okay, for the following reasons, class. Individualized dosing leads to higher efficacy and lesser toxicity. Aminoglycosides exhibit the same pharmacokinetics but differ in target concentration. Okay, meaning almost all aminoglycosides, tobramycin, gentamicin, amikacin, okay, these medications class tend to have the same pharmacokinetics. Yun nga lang, nag-iiba lang sa, adjust natin ito. Okay, nag-iiba lang class sa target concentrations. Okay, hence, giving them different doses. Aminoglycosides are excreted unchanged by renal GFR. So, their elimination is directly proportional to your patient's GFR. Okay? So, kumbaga class, the thing with aminoglycosides is they are normally excreted by the kidney. So, very important ang role ng kidneys when we're computing for the dose. So, if the kidney is functioning well, we will just give the regular dose. If it's not, we have to adjust the dose. So, how do we estimate the elimination rate and volume distribution for all aminoglycosides? Pretty much similar lang naman. Okay, normally, kailangan mo muna mag-compute ng CGEQ. So, CGEQ class is the preferred formula for estimating creatinine clearance for aminoglycosides. So, whenever you're facing class A patient using aminoglycosides, okay, CGEQ na klasang gamitin nyo, wag na natin gamitin yung MDRD. Okay, kasi nga, matagal na ang mga aminoglycosides class sa market. So, hence, yung dosing adjustment niya is based on CGEQ. Okay? So, this is the formula for the female. Okay, and here's the formula for the male. Okay, CGEQ. So, some things we have to consider, class. Age should be in years. Okay, weight should be the patient's ideal body weight or adjusted body weight for obese patients in kilograms. And serum creatinine should be in milligrams per deciliters. Okay? So the question now is, how do you compute for, okay, how do we compute for ideal body weight and adjusted body weight? So creatinine class is produced by muscle metabolism and not by fat. Hence, IBW is used. Kaya ang explanation nga natin kanina class is IBW tends to measure lean body weight, meaning only considering your muscle mass, not much on your fats. Right? So when we do ideal body weight, okay, so for male, that's 50 plus 2.3 for each inches above 5 feet in height. So say for example, class, in my case, I'm 5'4", okay, in height. So that's, so 50 kilograms plus 2.3 multiplied for every inch above 5. So I am 4 feet above 5. So that gives me 2.3 times 4, it's 9.2. So that's plus 50, obviously. 59.2 kilograms yung aking ideal body weight. I'm already 65. So I'm a little bit above my body, my ideal body weight. Okay? Sige. Ibig sabihin lang nun, kailangan ko mag-exercise. Now, for the female naman class, it's 45.5 kilograms plus 2.3 for each inch over 5 feet. Okay? Now, here's the question. Okay, not everyone is greater than 5 feet. Right? Okay, may mga tao mas maliit sa 5 feet. Excuse me. Right? Adults to, please take note. We're referring here to adults. Kasi kung yan class ay pediatric, normally we just use the actual body weight of the pedia patient. Especially kung less than 5 feet siya. Pero kung mas matangkad na siya sa 5 feet, then we can start computing for adjusted body weight. Alright? Now, if our patient class is, if our patient is 4 feet, below 4 feet, below 5 feet, then subtract 2.3 for each inch less than 5 feet. However, may limit yan. If patient is shorter than 4'10", okay, shorter than 4'10", IBW will be capped at 45.4 for male, okay, and 40.9 kilograms for female. Alright? So, halimbawa, ang kanyang height is 4'9". Ay, kung 4'9 class lalaki, matik, hanggang 45.4 lang ideal body weight nun. Kung babae naman ay 4'9", 40.9 kilogram lang. Okay? Magka-cap tayo doon. This is for adults. Again, I have to, kailangan ko dikdik to. Pang adults ito. For pediatric kasi class, normally we use the actual body weight. Not unless the pedia patient is, ang height niya is greater than 5, then we use the ideal body weight. Okay? Or greater than their own actual body weight. Right? So, halimbawa class, what if my patient is 4'11"? Alright? So, ibig sabihin, 1 inch less than 5. 1 inch lang kulang niya sa 5. So, therefore, kung ito ay male, kasi ang height niya is 4'11", so therefore, that's 50 minus 2.3 times 1. Kasi 1 inch na lang ang kulang niya for 5 feet. So, that would mean 50 minus 2.3. That gives you 47.7 kilograms. Ito yung magiging ideal body weight ng lalaking mas maliit pa sa 5 feet. Buti na lang hindi ako umabot sa ganon. Okay? Yeah. What about adjusted body weight? Alright, so for adjusted body weight naman class, okay, it's your IBW plus 0.4 multiplied to total body weight minus ideal body weight. Okay? The question here normally class would be, sir, when should I use adjusted body weight? Okay? Normally class, if the patient's actual body weight is 30% above his or her ideal body weight, then we are going to use adjusted body weight. Okay? For CGEQ computation. So, basta it's 30% above the patient's ideal body weight, then we start using, we start using, adjusted body weight. So, how do I know na 30% above na yung aking actual body weight? Say, for example, class, in my case, it's, ideal body weight, 59.2. Okay? So, say, for example, class, my body weight, my ideal body weight, IBW, is 59.2 kilograms. Now, my actual body weight, or sabihan total body weight na lang, is 65 kilograms. So, am I 30% higher? Okay, normally class, when you do that, that's just TBW divided by IBW. Okay, so that's 65 divided by 59.2. 65 by 59.2. Hindi pa. Okay, 1.09. I'm only 9% higher than my ideal body weight. So, goods pa yung 65 kilograms ko. Okay, I'm still good. So, I mean, I'm not yet, maybe I'm a little overweight, pero not that much pa naman. Okay, so yun siya. Now, what if class, what if my total body weight, my actual body weight is 95? 95 kilos. Okay? If that's 95 kilos, so 95 divided by 59.2, okay, that would give me 1.6047. So, times 100 mo yan, ang lalabas yan, class, is 160, right? 160%. 160%. So, meaning, it's already 60% higher than my ideal body weight. So, pag ganyan kas ang timbang ko, automatic, ang gagamitin ko is adjusted body weight. So, when computing for adjusted body weight, class, is just simply IBW. So, that's, my ideal body weight is 59.2 plus 0.4. Okay, ba't ko siya in-enclose? Anyway, so total body weight ko would be 95 minus 59.2. Kunwari lang naman kasi yung 95 na yan, ha? Alright, so that's 59.2 plus 95 minus 59.2 gives you 35.5 times 0.4 plus 14.32 plus 59.2. Ang kalalabasan is 73.52 kilograms yung adjusted body weight ko. And yan yung weight na gagamitin ko for CGEQ. Okay, hope that makes sense. So, some considerations for the elderly. Okay, some consideration. So, elderly tends to have lesser muscle mass. So, therefore, class, it's expected na mas mababa ang kanilang serum creatine production kasi lesser ang muscle mass nila. Okay? So, therefore, lesser serum creatinine could lead to an unrealistically high creatinine clearance. Sabihin, oh, ang ganda ng kidney function niya kasi konti lang yung serum creatinine. Yun pala, hindi naman sa dahil maganda ang kidney function niya kaya mababa ang serum creatinine. Mababa ang serum creatinine ng patient kasi lesser ang muscle mass niya. Make sense? Okay? So, it leads to an unrealistically high creatinine clearance. So, what are some of the recommendations? Some of the recommendations, class, includes round the lower serum creatinine values of elderly up to 1 milligram per deciliter before calculating creatinine clearance. Now, that's highly debatable. So, kung mga class, if your patient is 66 years old, 67, or 70 years old, pag lumabas na serum creatinine niya, class, is 0.9. Wag naman yan. 0.5, kunwari. Milligrams per deciliter based dun sa lab results. Pag nag-compute ka raw ng creatinine clearance, i-round up mo na raw yan to 1 milligram per deciliter for a patient who is greater than 65 years old. But that's highly debatable. Okay, that's highly debatable. Alright? Or round the calculated creatinine clearance down to 100 ml per minute or less. Again, these are all highly debatable recommendations. May mga nagsasabi kasing class, mga doctors, wag na, as is mo na lang siya. Okay? May mga iba naman na hindi, kailangan natin i-adjust ang serum creatinine because of 1 mg. Kasi kailangan 1 mg per deciliter yan. Okay, so, when this comes, class, pag ito ay lumitaw na sitwasyon, okay, anong gagawin mo? I-round up ko na lang ba ang serum creatinine sa 1? Or i-round down ko yung creatinine clearance ng patient ko to 100 ml? Okay? Kung sobra sa 100 ml daw yung okay, ang computation mo. So, class, personally, pag ganyan, gagawin ko, Doc, anong gusto yung gawin natin? Right? Tanong ko na lang kay doktor. Right? Pwede. Okay, pero normally, class, I just stick to kung ano man ang nakuha kong serum creatinine. Ay, pagdadasal ko na lang na na maging okay naman si lolo o si lola. Kasi class, if I stick kasi to the original concentration, remember, aminoglycoside kasi dose-dependent killing. The higher the dose, the better. Okay? Yun yung pananaw ko, ha? That's based on my own years, a few years of clinical practice. Okay, so my years of clinical practice. So I just stick with what's the original creatinine clearance. Okay, I don't round up. Okay, kung ano man yan, yun na yun. Alright, yun ang ginagamit ko usually. Alright? So, yun. So, class, in our case, pag nagpa-quiz naman ako, sasabihin ko naman kung kailangan nyo i-round up yung serum creatinine sa patient natin. Pero again, normally, class, we just stick with what's the given creatinine, serum creatinine. Okay? Yan ang pinaka-safe kasi na gawin natin. Okay? Okay. Kasi class, the thing with rounding up serum creatinine is it can lead to an underestimation of aminoglycoside dosing. So, halimbawa, 0.5, tapos ginawa kong 1. Ang nangyayari kasi classes, mas mababang dose ang bibigay ko kasi sabihin ko, ay, okay naman yung kidney function niya. Eh, di ba, sabi ko nga, with aminoglycosides, ang kanyang kill capacity is very dependent on the dose. The higher the dose, the better. So, gawin ko usually yung klase, bigay ko high dose, pero igagawin kong less frequent yung dosing ng patient ko. Right? Okay. Next. So, how do we calculate for the elimination rate of our patient? Okay. Normally, class, meron tayo dyang established na, correlation. Alright. So, the slope kasi class of aminoglycoside versus creatinine clearance is 0.00293. So, when creatinine clearance is 0, aminoglycoside clearance is approximately 0.14. So, therefore, class, when we're computing for the K, di ba nasanay tayo, half-life divided by 0.690 divided by half-life when we're computing for K. For aminoglycoside class, we don't do that. We use the population estimate, which is yung established pala na linear correlation, which is 0.00293 multiplied to your creatinine clearance plus 0.014. Kaya yung linear equation ng elimination rate constant ng aminoglycoside. Okay? So, standard ito. So, very dependent tayo sa creatinine clearance to determine for the elimination rate. Now, what about for volume distribution? Volume distribution class is simply 0.24 multiplied to the weight of the patient, normally ideal body weight niya. Ito pa nga pala. Okay, before I forget. Sometimes kasi this one happens. Minsan, ang ideal body weight ng patient is higher than the patient's actual body weight. Say for example, kunwari lang to class, ang ideal body weight ko, diba, based on my height, which is 5'4", is 59.2 kilograms. Now, what if nag-decide ako mag-diet, and then what happened is my actual body weight is 50 kilograms. So, anong gagamitin ko pang compute ng creatinine clearance ko? 59.2 or yung aking actual body weight? Okay? Obviously, class, if this happens, you'll be using your actual body weight. Bakit? Class, pag ginamit ko ang 59.2, saan nanggaling yung excess 9 kilograms na yun? Okay? That's that would be an imaginary weight. Okay? So, walang panggagalingan yung 9 kilograms na yun. So, therefore, class, I'll be using my actual body weight. Again, we only use actual body weight, class, if your actual body weight is lesser than the ideal body weight. Okay? Kung hindi pa rin ito, class, mag-gets, i-rewind nyo yung part na to. Alright? Very good. Okay. So, some considerations. The values for K and VD represents population estimates with relatively large standard deviations. For patient-specific pharmacokinetic data class, it's important that we get an actual peak and trough concentration so that we can get the K. We can get an actual K. Alright? Basta kasi itong peak and trough concentration na to, this should be at steady state. Alright? Kasi diba, if you have two concentrations, madali na lang kumuha ng K. Right? Because when we compute for K, that's just ln C1 minus ln C2 over T. The time that lapse between the two concentration. Okay? And that's how we get actual K. Now, of course, kasi between population estimated K versus the actual K, mas maganda yung actual K. The actual elimination rate. Kasi again, ang ginagawa lang nandito is just an estimate. It's just a population estimate. Okay, kasi syempre, umpisano pa lang naman yung aminoglycoside treatment ng patient. So, wala ka pa talagang actual pharmacokinetic parameters. Okay? Now, what is the desired aminoglycoside plasma concentration for gentamicin and amikacin? Now, as I've mentioned a while ago, class, both of these aminoglycosides have the same pharmacokinetics. The only difference is their desired therapeutic concentration. For gentamicin class, ang ideal peak is between 4 and 10 milligrams per liter. For amikacin naman class is between 15 and 30 milligrams. Now, for their desired trough concentration, okay, steady state to so gentamicin and tobramycin classes between 1 and 2, while for amikacin it's between 5 and 10. Now, some considerations that you have to take note of. Okay? Adequate peak equals efficacy. So, meaning the higher the concentration, the higher the peak concentration, the better will be its efficacy. Now, a lower trough concentration leads to a lesser nephrotoxic and autotoxic phenomenon. Okay? Lesser ang chances. So, meaning class, whenever we're computing for its dose, ang target natin lagi is the lowest possible minimum concentration. So, kung magamit tayo ng gentamicin, target natin is 1. Kung gagamit tayo ng amikacin, ang target natin is 5 na trough concentration. Alright? Now, kung ang resulting trough concentration class is less than 5, okay lang yun. Bakit? Aminoglycosides has a long post-antibiotic effect. What do we mean by a post-antibiotic effect? It means, class, that aminoglycoside, even if its concentration is less than the minimum inhibitory concentration niya, it's MIC. Kunwari, ang gentamicin, 1 ang kanyang MIC. Ang nakuha kong actual MIC, ang na-compute ko is lalabas sa 0.8. Carry na yan. Okay na yan. Huwag mo nang i-adjust pa ang dose na taasan mo para ma-meet yung 1. Okay na tong 0.8 na to. Bakit? Kasi nga, class, aminoglycoside has a long post-antibiotic effect. Meaning, even if the concentration, the trough concentration is less than the minimum inhibitory concentration, it can still exert its antimicrobial property. Are we clear? Plus the fact, class, na kapag mas mababa ang trough concentration natin, mas less ang chance na magkaroon ng nephrotoxic or autotoxic problem ang patient natin. Okay? These are the things, class, that I need you guys to remember when you're adjusting the dose. Right? Baka mamaya pagpilitan mo, hindi, dapat higher than 1 yan. Okay, no. If it's less than 1, class, that's better. Okay, that will actually be better. Right? Kasi nga, less ang chances for nephrotoxic and autotoxic property. Now, for the peak concentrations, class, we always aim for a high peak concentration as much as possible. Okay? Again, class, if you want to avoid kasi toxicities with aminoglycosides, aim for a lower trough concentration. Or kung talaga mataas ang trough concentration, habaan mo yung frequency. Habaan mo yung dosing interval. Instead na every 8 hours, gawin mo every 12 hours. Okay? Lesser ang chances na magkaroon ng toxicity yun. Alright? Tandaan nyo, kayong tatanungin ng doktor dito. Okay, kung tipong ganyan ang mangyayari, no? Dok, kayo na ho bahala. Wag naman sana. Gawin natin trabaho natin, no? So, target for the lowest semin possible. Aminoglycosides are given by infusion. And the infusion class, the usual, pwede, ang doktor kasi minsan, gusto 30 minutes lang. Pero, pagpilitan mo 1 hour para mas madali. Okay, for its simplicity. Yun naman yung standard eh. Alright, so let's now talk about class A sample case study. Okay. Separate case problem. Lipat lang natin ito. Right, so we have here, class, a 66-year-old white female, SG, okay, is hospitalized for lysis of adhesion secondary to previous bowel resection. Okay, so before surgery, you are asked to begin this patient on aminoglycoside. Other pertinent patient information includes the height, which is 5'8", weight is 52 kilograms, and serum creatinine, which is 1.02 milligrams per deciliter. Alright, so with this information, class, we can start computing now for our patients aminoglycoside dosing. Okay? Now, however, may mga side notes pa dito for the case. Okay, so ang sabi dito is calculate for an appropriate gentamicin maintenance dose and loading dose. So both maintenance and loading. Include the most appropriate dosing interval for patient SG. Assume that the desired C peak, okay, sinabi na sa problem, no, is 6 milligrams, although we know that it's between 5 and 10. Okay, and then the trough is 1. Okay, the ideal trough concentration is between 1 and 2. So, tama naman, at least ang sinabi dito is yung sa lowest possible, which is 1, ang target natin. So to solve the problem, class, we will have 6 steps. First is to determine the IBW and creatinine clearance. Okay, second is to insert population estimates, okay, for VD and K. Then third would be to choose the desired peak based on the clinical and microbiological data. Okay, so usually determined na to, or sinasabi naman sa atin. Fourth is the determined infusion time. Pero actually, alam natin kung ano infusion time natin. It should be 1. It should be 1. Okay, calculate an appropriate dosing interval. Determine, and the last thing would be to determine the dose. Okay, the rate of infusion as for maintenance and loading dose. Of course, kasi it will be in milligrams per hour. Since 1 hour lang yan, so madali na lang yun. Okay, so first things first. Compute for ideal body weight. So to compute for ideal body weight, class, for a female, since it's a female, our patient is a female, so 5'8" ang kanyang height. So therefore, it'll be 45.5 times plus 2.3 times 8. Okay, so 63.9 kilograms. However, ito, babalikan natin. Ano ba ang weight ng patient natin kanina? Ideal body weight is 63.9. But, our patient's actual body weight is only 52. Technically, parang ano to medyo underweight ang patient natin. So, sabi natin, class, di ba? Pag mas mababa ang actual body weight ng patient kaya sa kanyang ideal body weight, anong gagamitin nating weight pang compute ng creatinine clearance? And that will be the actual body weight, which is 52. Alright? So, in this case, gagamitin natin is 52 kilograms. So, yung creatinine clearance, class, is apply the formula for a female. Okay? And then, ang resulting creatinine clearance, sabi natin, SG's actual body weight ang gamit natin. 52. Hindi yung kanyang ideal body weight kasi mas mababa ang actual body weight. Ang kalalabasan class na creatinine clearance is 44.54 ml per minute. Female. Next would be to estimate for the elimination rate constant. So, sabi natin, ito lang ang formula natin isasaksak dyan. Okay, so isaksak natin yung ating creatinine clearance, which is 44.54. Lalabas would be 0.1445. Okay, for the elimination rate. Okay, for the sake of determining lang ang half-life natin, it's going to be 4.8 hours. Kasi class, para malaman natin kung gaano katagal tayo mag-aantay before steady-state concentration is reached. Next one is volume distribution. So, volume distribution is simply yung weight na ginamit for creatinine clearance. Multiply natin by 0.24. So, in this case, ang ginamit natin is actual body weight instead of ideal. So, therefore, ang lalabas would be 12.48. So, now, we already have our K. We have our VD. Okay? Alam na rin natin ang peak desired natin at saka yung trough concentration desired, right? It's going to be 6, 1. Tapos ang infusion time natin is standard 1 hour. Alright? Now, the next na kailangan natin kasi determine is dosing interval. What would be the best dosing interval for our patient? So, the choice of dosing interval influences the peak and trough obtained as well as the magnitude of fluctuations in your peak and trough concentrations. So, to compute class trough concentrations, we'll be using this formula. Okay? So, that would be 1 over K. So, actually, pag sinulat ko to class, that's tau equals ln C peak, yung desired, minus ln C trough over K plus your infusion time. Okay, so to compute for this, we have the following. ln 6 minus ln 1, it's milligrams. Okay, that's milligrams per liter plus 1 hour. Okay, divided by 0.01445. Ang lalabas dyan would be 13.4 hours. So, obviously, class, wala naman tayong every 13 hours na dosing interval. Again, ang dosing interval natin, class, should be a number that can divide 24 hours para consistent yung pagbigay ng gamot. So, instead of 13.4, obviously, we'll be rounding it down to 12 hours to fit a 24-hour cycle. Okay? So, round down natin 12 hours. Now, for the maintenance dose, we'll be using this formula. Okay? So, for this problem, maintenance dose will be computed first before loading dose. Okay, mas madali kasi. So, to get for maintenance dose, that's just C peak multiplied to VDK times 1 minus E negative K tau over 1 minus E negative KT. So, ang lalabas class dyan would be, ang desired natin na peak would be 6. V9 is 12.48, then K is 0.1445 times 1 minus A negative 0.1445 times 12, which is our dosing interval. Then 1 minus A negative 1445 times 1, which is infusion time natin. At ang lalabas class na result dyan would be 66.24 milligrams. Now, 66.24 milligrams, in practice, the dose will be rounded to 70 milligrams infused for 1 hour every 12 hours. Actually, pwede ba nga ito 80 milligrams pero mamaya natin pag-usapan yun, ha? For now, let's stick to this muna. It'll be 70 milligrams. Now, since we rounded up the dose, C-peak would also increase. So, let's check if it's still within range. So, remember this formula pag ginagamit natin pang check. Okay, since binago natin yung dose, 66 dapat ang dose, pero ginawa natin 70, so nagtaas tayo ng dose. So, therefore, class, yung actual dose over the rounded dose. Okay, so that will be 70 divided by 66.24 times 6 mg per liter, yung desired level natin. Kaya lalabas sa 6.34, which is technically pasok pa rin naman sa 4 to 10. Okay, sabi natin, the higher nga, the better, di ba? Okay, basta wag lang yung trough concentration. So to minimize toxicities, the C-mean should be as low as possible. So that depends on the clinical judgment. This will depend on your clinical judgment. So to get the estimated trough concentration class, we'll be using the formula C-peak SS E negative K T prime. Okay? So this ito yung formula natin for infusion. That will be 6.3 milligrams per liter. Okay? Ito yung ating peak concentration na lalabas gamit ang 70 milligrams na dose times E negative K. Tapos ang T prime natin would be dosing interval minus infusion time. At ang lalabas would be 1.29 milligrams per liter. Allowable naman is 1.2, so technically pwede na rin. Okay? 1.29. Now, if the C mean was close or above 2 milligrams per liter, toxicities might be observed. Therefore, we could prevent that by increasing the dosing interval. So instead of every 12 hours, every 16 hours. Again, depende pa rin naman sa iyo to eh. Okay? Or decrease the dose. You just decrease the dose. So either way, class, either habaan mo yung dosing interval or babaan mo yung dose. So isipin nyo, class, di ba ang hirap? Kasi i-check mo na naman afterwards. Okay? Kaya buti na lang gumawa tayo ng Excel file for that. Okay? Pero mamaya natin pag-usapan yan. Now, to compute for loading dose naman, class, it is given to immediately achieve a concentration near that of the desired CPSS. So, in clinical practice, class, loading dose and maintenance dose are computed at the same time. Now, to compute for loading dose, gagamit tayo ng formula na ito. CP equals rate of infusion divided by VDK times 1 minus E negative KT. Okay, so transpose the formula to get your formula for loading dose. Okay, C peak to be used should be the desired peak instead of the actual peak. So, ang desired natin would be 6 milligrams per liter here. So, apply again the values. Ito yung 6 milligrams per liter. Lalabas class would be 80.42, which is the standard dose, 1 vial. Okay, normally, I think it's 2 ml o 1 ml. 80 milligrams per ml yata ang isang vial ng gentamicin. If I'm not mistaken, ha. Okay, so another formula that we can use would be maintenance dose divided by 1 minus E negative K tau. Pwede rin yun. Kaya nga pinakompute muna natin yung maintenance bago tayo nag-loading dose. So kung 66.24 ang maintenance dose, lalabas dyan na loading dose would be 80.44 pa rin. So in conclusion, okay, loading dose should be 80 milligrams infused for 1 hour. Maintenance dose would be 70 milligrams infused for 1 hour. The best dosing interval would be every 12 hours. Estimated peak, pag ito yung dosing regimen natin, 6.34, which is pasok pa rin naman sa desired. Okay, and then the estimated trough concentration will be 1.29, between 1 to 2. Steady state concentration will be achieved at, so dahil 4.8 ang ating half-life times 5, approximately 24 hours. Okay? Okay. So now, class, sabi ko sa inyo, ang hirap, di ba? Kasi ka magde-decide, babago-baguhin pa yung data dyan eh. So let's try to use Class A software, actually an Excel file, to compute for this one. Okay? Sige, keep ko muna. Here's an example class of my of an Excel file which uses class gentamicin, which can be used for gentamicin and tobramycin. Alright, balik tayo sa problem. Okay. So here class, pipili ka, okay, depende kung ano yung patient mo, male or female. Obviously, in this case, our patient is female. So dito tayo sa female dosing. Right? Naka-pink yan. Para hindi mahalata agad. Sa male, blue. Babae, female. Itong dose checking, ito pag nabigay na yung gamot. Okay, ito naman ginagamit. Excuse me. Pag nabigay na yung gamot ng patient. Huwag nyo napansinin ito, ha. Huwag nyo napansinin sheet 2 at saka itong levels. Just don't mind that. Huwag nyo lang galawin yan. Dito lang tayo sa dose checking or sa dosing. Okay, so in our case, class, magdo-dose pa lang tayo. Mag-umpisa pa tayo ng dose. So dito tayo sa female dosing. At babae yung patient natin. So our patient is 66 years old in years. Height should be in inches here. Okay, inches itong nakalagay dito. So 5'8 class would be, 5 foot is 60, so 68 inches. Okay, 68 inches. Ang weight natin class is 52 kilograms. Abangan mo class dito yung, wait, lakyan natin ng konti ito. Okay, itong green na to. Right, yung green na yan. So, ang weight natin currently is 52 kilograms. Right? So, class, kung saan humantong yung green na yan, yun yung weight to use. Kasi halimbawa, ang weight ng patient ko is 95 kilograms. Tingnan niyo, bababa siya. Sabi niya, gamitin daw natin is adjusted body weight. Kung 95 ang kilos ang weight ng patient natin. Eh, hindi naman yun ang weight ng patient natin. Ang patient natin is 52 kilograms. So, dito nag-end yung green na to. Okay, yung marker na yan. Ibig sabihin, the weight to be used is 52 kilograms. Alright? Para hindi na kayo nahihirapan. Okay, halimbawa, class, ang weight ng patient ko is, kunwari lang naman, 69 kilos. So, sabi niya, dito tayo sa ideal body weight. Ito yung gagamitin nating weight. Andyan yung green. Okay, pero again, ang weight ng patient is 52 kilograms. We'll be using the actual weight. And just so you know, class, interpretation niya is underweight ang patient natin. Okay, so our patient is currently underweight. Now, ang serum creatinine ng patient natin is 1.02. And that's a bit high for an elderly. Okay, and the creatinine clearance class is kinda low. Okay, kasi mataas ang serum creatinine, may iwan siya. Okay, so ang galing, no? So anyway, what's the K to be used? Now, class, may binigay kasi ako dyan na K. Average elimination rate constant. This one is the population estimate. Kung hindi mo, class, alam ang creatinine clearance ng patient mo, ito yung gagamitin natin. 0.3465. Kung hindi natin alam. Pero alam natin ang creatinine clearance ng patient natin, so therefore, we'll be using 0.1445. Nag-compute na siya. Yan ba yung na-compute natin kanina? Okay, ito. Creatinine clearance natin is 44.54. Approximately 45. Round off niya na. Alright? So here, it's 45. Hope nakikita nyo. Tapos ating K is 0.1445. So here, it's 0.1445. Okay, so ang K to be used would be 0.1445. So type natin yan, 0.1445. Alright, next class is the desired concentration. So based dun sa problem natin, ang sabi is 6 ang peak, 1 ang trough. May recommendations na rin ako dito. So recommended is 7 kung hindi mo alam, pero sabi sa problem is 6 daw yung i-target natin. So sige, let's just stick with the problem. So 6 and 1. Okay? Yun. So now, for the dosing interval, infusion muna. Infusion time is 1. So ang sabi dito, dosing interval is 13.4. Here. Okay, 13.4. So tingnan natin ang na-compute natin kanina. It's 13.4. Pretty much the same, right? Okay, so 13.4. So obviously, sabi natin walang ganon. So gamit natin ay 12. So, ang sabi sa akin dito, loading dose daw should be 80.42 while maintenance dose is 66.22. So, yun din ba ang na-compute natin kanina? 66.24. Konting difference lang naman. Alright? Tapos, ang ating peak, ang ating dose, loading dose is 80, right? So, let's stick with that. So, sabi natin dito, 80 ang ating loading dose. Maintenance dose natin is 70. Kaya 70. So, kung titingnan nyo dito, class, sa kabilang side, here's the estimated plasma concentration. If I use 80 milligrams sa loading dose, ang lalabas na peak concentration, ang estimated peak concentration, computed peak concentration is 5.97, which is ang remarks, okay. So, kunwari, loko-loko ako, gusto ko doblein 160 ang bibigay ko. 11.94 yung lalabas na peak concentration. And it will tell you na you need to monitor the patient. Kasi masyadong mataas yung 160 for them. Right? Pero sige, ang sabi natin is 80. Let's stick with 80. Okay, dito sa ano, ito yung loading dose. Now, tingnan natin class, 70 kasi ito ang maintenance dose. Ang lalabas daw is 6.34 na peak concentration at 1.29 na trough concentration, which is pretty much okay, right? Pero sabihin natin class, para hindi na mahirapan ang nurse natin, bigyan niya na lang din ang buong vial, sayang naman yung excess 10, tatapon lang ba yun? So magbuong vial tayo, try natin kung ano lalabas. 7.25, 1.48. So technically, pwede pa rin naman. Hindi pa naman malapit sa 2 ang 1.48, right? Malayo pa naman siya, right? Okay, so pwede pa ang 80 milligrams dito. Okay? So yun, so okay pa siya. Pero halimbawa, class, ginawa ko maintenance is 160, double dose ko. Okay, sinasabi na dito agad, it's toxic. Huwag mo na raw subukan yun. Maintenance dose na 160. So let's just stick to 80. So technically, pwede na yan. Okay? Pasok pa rin naman siya sa therapeutic range at hindi pa naman malapit sa 2 yung trough concentrations. Okay, although the lesser the better, pero kinibubo. Pwede na yung 80 para di sayang. Anyway, kasi yung volume to be used dito would be yung stock dose lang naman. Ang usual lang naman dito na stock dose is 80 milligrams per 1 ml. 80 per 1 ml. So, sabihin, 1 ml lang gagamitin, isang buong vial. Now, diluent, say for example, NSS. Normally, yung NSS na ginagamit is 100 ml. Okay? Ay, mali, ano ba yan? NSS pa lang ginagamit natin. Sorry, NSS. Type mo lang dito. Yung dito sa side na to. Ang gamit natin is NSS, pwede D5 NSS. Pero usually, NSS lang yun. D5 ginagamit yung class pag NPO ang patient or di makakain. So, bibigay ka ng D5. Tapos, ang total volume would be either 100 or 500 ml. So, normally, it's 100 ml. Infusion rate na ilalagay nyo dun sa ano would be 1.67 ml per minute. Okay? Kung meron siyang infusion pump. Kung wala, manamanuhin na lang ito ng nurse. 1.67 or 2 ml per minute. Pwede rin naman. Pero 1.67 na parang di masakit. Alright, and here's the summary. So, ito yung bibigay natin sa nurse natin or sa doctor. So, doc, ang loading dose natin is 80, maintenance is 80. Bale, 1 ml yun ng vial. Dosing interval natin is 12. Infusion time is 1. Infusion rate is 1.67. Diluent natin is NSS. Tapos, ang total volume nun is 100 ml. Right? Mas madali, right? Okay, pwede mo pang bago-baguhin dito. Check-check mo lang kung halimbawa, kung gaano karaming bibigay mo. So on and so forth. Alright? Okay. So I hope that's clear. Okay, dokie. So let's go back to our slide here. Saan na ba tayo? Ayun. Getting the actual pharmacokinetics. Sabi ko nga sa inyo, class, excuse me, between population estimates and actual pharmacokinetic parameter, it's always better to get the actual pharmacokinetic parameter. The problem lang with this one is, kailangan nasa steady state na yung concentration ng patient. Okay? So things to remember, yun na nga. Upon using population estimates and getting the dose of aminoglycoside, you can start taking actual peaks and trough to compute for actual K and VD of the patient. So, patient-specific to. After steady state is reached. Just so you know, class, yung Excel file ko, ako gumawa na ako dati ng pwede for for actual Titignan ko na lang. Okay, pero yung design nun is for the population estimate. Right? So we use population estimates first to compute for dosing. So after reaching the CSS, we can now adjust the dosing based on the actual PK. So as based on our computation a while ago, 4.85 ang half-life, so times 5, that's approximately about 24 hours, right? So after 1 day of using that treatment, pwede na tayo kumuha ng peak and trough concentrations. Okay? So actual concentrations are only taken when patient has no clinical improvement after 3 days, and patient is experiencing adverse drug reactions, such as there is an increase in serum creatinine. Now, class, ito ulit ang kailangan nyo tandaan. Kasi madalas ko tinatanong ito sa exam. Okay, or minsan tatanungin ko, is after 24 hours, patient should be getting serum concentrations. So, after 24 hours pa lang, class, hindi pa ideal na kumuha ng peak and trough concentration. Tandaan nyo, babayaran ng patient yan. And it's very expensive to get actual peaks and trough concentrations. Magpa-determine yan. Okay, it's expensive. So therefore, class, normally we have to wait for 3 days. Kung 3 days na, hindi pa rin nawawala ang fever ng patient. Kumbaga, mahina pa rin kumain ng patient. The drug is not working, then that's the only time we start getting peak and trough concentrations. Just so you know, class, bago ka syempre gumamit ng antibiotics, malamang naman siguro nagpa-culture and sensitivity na yung patient, right? To determine whether or not the patient is sensitive to aminoglycosides or not. Okay, pero kung walang pera ang patient, tapos feeling natin gram-negative, feeling ng doktor gram-negative yung bacteria, gora bumbum. Okay, pero kung after 3 days, wala pa ring results, wala pa ring improvement, clinical improvement ang patient, then, well, number 1, check nyo muna, pa-culture sensitivity muna kayo, baka may resistant pala yung bacteria sa aminoglycosides. Or number 2, kung susceptible naman yung bacteria, magpakuha na tayo ng peak and trough concentrations. Pwede kasi ang dose na binigay natin is medyo mababa for the patient. Okay, so hindi siya nag-respond. Or, normally kasi magpapakuha ka ng peak and trough concentration if the patient already start to experience adverse drug reactions, such as nag-ringing na yung tenga, nag-ring, ibig sabihin nag-autotoxicity na siya, or, yun na nga, tumataas yung serum creatinine ng patient natin. Okay? Yun yung mga abangan natin. Right? So, recommendations. Okay? When you're getting C-peak, okay, kung i-determine mo yung actual C-peak, usually you measure that at the end of the 1-hour infusion. Okay? Usually, it's after 30 minutes after the end of the 30-minute infusion, kung 30 minutes man, basta after the end of the infusion, or 1 hour after an IM injection, kung in-IM yung aminoglycoside. Then C-mean class is measured approximately 5 minutes before the dose is due, or before the next dose is given. So say for example, class, next dose natin is 8 a.m. So dapat 7:45 a.m. get blood for trough concentration. Okay? At least 5 minutes before. Okay, for ease of taking blood sample, semen is taken first before the C-peak is taken. So kumbaga, bago ka para mas mabilis tayo mas mabilis magkuha ng sample, okay? Kumbaga, kunin mo na yung semen. So after nun, bigay mo yung yung dose para makuha naman yung peak concentration. So trough and peak concentrations. Para konting oras lang aantayin mo. Isang oras lang aantayin mo. As compared naman kung every 8 hours yun, walong oras ka mag-aantay bago makuha yung trough concentrations mo, right? So, kunin mo na yung trough, tapos mag-aantay ka lang ng 30 minutes or 1 hour, then to get your peak concentrations. So, let's continue the case na class. So, this time, ipagpatuloy natin. After giving the, computation for the peak concentrations, after getting the giving the dosing interval, the dosing regimen of our patient, theoretically ano nangyari sa patient natin. To continue with patient SG from case 1, blood was drawn for drug concentration assessment around the 4th dose. So approximately 5 minutes before the dose was due and immediately after 1 hour dose infusion. C-peak and trough were determined as follows. Trough was 0.4. So, technically, mas mababa pa sa na-compute natin. Tandaan nyo, class, it's normal to get, it's normal to get differences sa actual at saka yung estimate na. Kasi estimate lang naman yun eh. So, ang trough natin is 0.4. Then, ito ginamit natin 70 milligrams. Hindi natin ginamit yung 80 milligrams. Okay, sa ito, nag-stick lang tayo sa 80 milligrams. 70 milligrams dose was infused. Then, ang peak concentration is 4.6. Now, if you notice, class, technically, okay lang din naman to eh. Okay, 0.4 milligrams. Pero if the patient is not responding well, is not yet responding to that drug, after 3 days, siguro pwede na rin i-adjust yung dose. Alright? So, looking at this class, we can determine na medyo mababa ang plasma concentration ng patient, especially for the peak and the trough. So, ang trough natin is between 1 and 2. Ang peak natin is between 5 and 10. So, it's kind of low. Sabi ko, dapat sinunod yun lang recommendation natin 80, no? Pero sabihin natin, 70 ang binigay eh. So, the first thing class na gagawin natin is to calculate for K. Alright? So, sabi nga, just use the actual peak and then the actual trough. So, ln ln 4.6 minus ln 0.4, which is the actual one. Then 12 minus 1, okay, which is the dosing interval minus the infusion time. And you get a K of 0.2220 per hour. Half-life would be 3 hours. So for VD naman class, we'll use this formula here. Okay, so substitute everything. And then you'll get class a VD of 14.67. Compare that to the 12 point something natin a while ago, right? So 14.67 pa lang actual, volume distribution ng patient natin. So let's calculate for a new dosing interval, okay, using this formula. So just substitute everything again, class. Ang lalabas dyan would be 9 hours. Okay, so obviously class, 9 hours is closer to 8 hours. So round down natin sa 8 hours. Okay? Yan. And then the new maintenance dose natin would be this one. So apply the formula here. So yung desired C-peak natin. Tandaan nyo kasi, ang C-peak dito would be the desired, not the actual. Kasi we're computing for a maintenance dose, a new maintenance dose. So ang VD natin is 4.67, this is the actual, and then the actual K. Substitute everything. Okay, dosing interval natin, infusion time. At ang lalabas dyan would be 81.53. See? They should have started with 80 milligrams in the first place. Okay, pero sabi nga, kasi mamano-mano mo to, mahirapan ka talaga. So, work ka sa exam natin class, Excel sheet ang, papagamit ko sa inyo yung Excel file natin. Okay, so in practice, the dose will be rounded to 80 milligrams infused for 1 hour every 8 hours. Right? So, check natin. Actual peak. Alright, so kung 80 milligrams ang gagamitin natin instead of 81.53, ang lalabas is 5.89. Estimate, more or less. Still, pasok naman siya sa 4 to 10. Then, for the trough concentration, okay, again, substitute everything. Lalabas is 1.25. So, still, pasok pa rin naman. So, in conclusion, maintenance dose na should be 80 milligrams every 8 hours. Ang difference ng class sa recommendation natin a while ago was 80 milligrams every 12 hours. Right? Pero ito, umaba siya. Gawin na lang daw every 8 hours. Okay? Kumbaga, mas umiksi yung dosing interval. Okay? Estimated peak is 5.89. Trough is 1.25. So, pasok pa rin naman. Steady state concentration will be achieved at 15 hours. Okay? Okay. So, let me just check. Keep. Okay. Alam ko pwede kong gamitin to eh. So, ang current maintenance dose natin was 70 for our patient. And dosing interval was every 12 hours. Wait, let me check. May naman the actual. Ay, wala. So, hindi nga. Pharmacokinetics, infusion rate. Estimate plasma concentration to eh. Yep, this is not the one. Puro. Okay. Ang checking lang pala talaga to. Okay, so, yun class. Although I know I have one, pero, okay, never mind. Basta yung class pag actual, yung computation natin. Okay, for actual pharmacokinetic parameters. Okay. So, wala pa tayong Excel sheet for that. Okay, let's continue on with the case. So, adjust tayo, nagtaas tayo ng dose. Nag-exceed tayo ng dosing interval. So, 4 days later, another set of peak and trough dime pera in patient are obtained. Patient SG has been receiving 80 milligrams every 8 hours. However, her renal function has declined, as seen by an increase in serum creatinine from 1.02 at baseline to 1.71. So, tumaas after 3 days. More than 3 days, after 4 days nga ito eh. C-peak and trough were determined as follows. 3.2 na ang trough concentration. Dapat hindi niya na, dapat hindi niya na binago yung every 12 hours na dosing interval natin. Pero, it happens. It happens. Okay? Tapos, ang peak concentration is 9.2. Pasok pa naman ang peak, pero ang trough ang problema natin dito. Should be less than 2 dapat. So, a new K, VD, and tau, and maintenance dose must be derived. So, new K, so just class ang gagawin lang natin dito is just reapply the formula. Okay? At ito yung lalabas na mga sagot. You can try this on your own. Okay? You can try to determine this one. Baga yung ginawa natin kanina for actual VD, actual K, Just have to redo it. Right? Okay. Sakali class, magpapaquiz man ako, konti lang naman ang tatanungin ko sa mga actual na yun. So things to remember, since we are decreasing the dose, before switching, we must wait for SG's trough concentration to decrease to approximately 1 milligram per liter. So the dose should be held for some time before the new lower dose is administered. Kasi tumaas yung plasma concentration natin. So therefore, the trough desired, okay, should be computed using this one. So what's the current trough steady state? Is E negative KT prime. So sabi nga natin, time needed to hold the dose after the end of the dosing interval. So, to get that class, para malaman natin kung gaano katagal tayo mag-aantay, kasi, originally, ang kanyang C-mean is here. 3.2. Ang kailangan nating C-mean is nasa 1 milligram per liter. Right? So, ang tanong lang naman dyan is, yung time na to, gano'n tayo katagal mag-aantay before we give the next adjusted dose. Just simply 3.2 minus 1, minus ln1. 3.2 is the actual. Minus 1 divided by k, which is 0.1509. Na-compute natin actual k. And then, class, ang waiting time natin will be approximately 8 hours. Okay? So, if this is the, if it is, ang first dose natin, 8 a.m., second dose, 4 p.m. Okay, so ang peak natin is 9.2, tapos kayo na is 3.2 at 8 a.m. So therefore, we have to wait until it declines to 1 milligram per liter. At ang sabi doon is 8 hours tayo mag-aantay. So at 4 p.m. pa, kumbaga skip this one, don't give the next dose at 8 a.m., give it the adjusted dose at 4 p.m. So, I hope that makes sense, class. Okay? Kasi nga, we need na mababa yung trough concentrations natin. Okay, before we give the next adjusted dose. Right? Now, what about class for extended interval aminoglycoside dosing? Normally, class, kailan to ginagamit? Kung yung dose adjustment natin ngayon na class is usually based on patients with technically normal functioning kidneys. Okay? Kung medyo okay pa naman yung kidneys. Now, what if magbibigay tayo ng aminoglycoside sa isang patient na sabihin natin naka-hemodialysis or patient na may diagnosis na renal failure, may it be acute or chronic, gagamitin natin kasi ang extended interval. Okay, aminoglycoside dosing. Hindi tayo magkikeme-keme pa. Okay, for this one class, ginagamit to for patients with declining renal function. So, the dosage interval is increased from 12 to 24-hour increments. Right? So, large doses, ito ang gagawin natin dito. Usually, we will give the patients large doses. Pero, ang interval natin, dosing interval natin is every 24 hours. Or, depende. Now, why use this? Okay, so why use extended interval aminoglycoside dosing? So, ginagamit natin ito class for the following reasons. First is, aminoglycoside is a concentration-dependent killer, meaning it kills bacteria based on its concentration. Okay, so the higher the concentration, the better. Excuse me. All right. So we can give class the concentration of aminoglycoside 10 times higher than the minimum inhibitory concentration, and that can give it bactericidal effects. Now, a second reason, class, would be because of its long post-antibiotic effects. Sabi ko nga sa inyo, okay, as long as we give the drug high, right, even if yung kanyang concentration is bumaba, mas mababa pa dun sa, tawag na dito, okay, mas mababa doon sa minimum, sa trough concentrations niya, okay lang, mamamatay pa rin yung bacteria because yun yung property ng aminoglycosides eh. They have long post-antibiotic effects. Okay? So, the amount of time that the drug may fall below the MIC before regrowth of the bacteria resumes. Oops. Alright, so what are other reasons? Okay, by giving the drug class at high amounts, okay, right, it actually gives you sufficient drug-free interval. So meaning may mga times na walang gamot sa katawan mo. And that prevents, class, the onset of resistance. Remember, class, what resistance does? Okay, the more a bacteria is exposed to a drug, mas na-develop, mas nakikilala niya yung drug, mas nakapag-develop siya ng resistance towards it. Kaya nga, ang daming resistance against penicillin, because penicillin is a time-dependent killer. It means the bacteria has to be exposed to penicillin for long periods of time before it dies. Okay, the setback of that, class, is it gives the bacteria enough time to get to know penicillin. Alright? So, yun. Kaya gumagamit pa rin tayo ng extended dosing interval para maiwasan ang resistance. And a possible decrease in toxicity. So, there's no definite evidence between the toxicity of multiple daily dosing versus extended dosing. However, there is a possibility na lesser ang toxicity doon. Kasi, once every 24 hours mo lang binibigay ang gamot at high dose. So, sino ang usually na binibigyan ng mga extended dosing? Alright? Normally, class, okay, ito, class, kayo magde-decide dito. Gagamitin nyo ba yung population estimate? Magko-compute ba kayo ng actual VDK? Or gagamit kayo ng extended dosing interval? I leave this to your discretion. Okay, pero class, there are specific conditions. Okay? Sa quiz natin, will be based dito. Alright? Hindi ko sasabihin kung ano gagamitin nyo, pero kayong bahala. Pero dapat kasi tandaan ninyo, pag ang patient mo ay may cystic fibrosis, automatic, mapa-adult or pediatric yan, extended dosing interval tayo. Merong neonatal infections. Okay, ayaw naman sirain agad ang kidneys ng baby. Kakapanganak niya lang. So, obviously, class, we will be using extended interval dosing there. Okay? Patients, cancer patients with febrile neutropenia, pediatric patients, normally, gagamit tayo ng extended dosing interval. Okay? Pero actually, may separate tayo ng computation for pediatric. Pero pwede rin gamitin sa kanila ito. Right? Na for kung may pedia patient tayo, class, na case example, say for example, kung may case tayo na ganun, gagamitin niyo yung computation na ginagamit for pediatric population. Or the patient has enterococcal or staphylococcal osteomyelitis, infection sa bones. So, gagamit tayo ng extended interval dosing. Aminoglycoside dosing for that. For those conditions. Right? So, what are the methods? There are 3 methods all in all, pero the usual class na ginagamit natin is method 1. This one. Okay, the 2009 Sanford Guide to Antimicrobial Therapy. Madali lang siya, class. Okay? Ang gagawin lang natin dyan, class, is, ang dosing natin is per kilogram body weight. Okay? For gentamicin and tobramycin, ang dose natin would be 5.1 mg per kilogram body weight for patients with creatinine clearance that is greater than 80 ml per minute. Okay? If it's greater than 80 ml per minute, pwede na yun. Now, if the patient is seriously ill, ano ba ang category pag seriously ill? Non-responsive, patient is in shock. Okay, pwedeng cardiogenic shock. Or talaga, class, severely ill ang patient. Makikita, hindi kumakain, pumapayat, naka-TPN. Naka-TPN na ang patient natin. Then we increase the dose, class, from 5.1 to 7 milligrams per kilogram body weight. Now, in our cases, class, sasabihin ko sa inyo kung ill o hindi ang patient. Kasi syempre, hindi naman natin trabaho mag-diagnose. We will be depending on the diagnosis of the doctor. So, sa mga cases natin, may mga diagnosis na yung doctors natin doon. Okay, sa mga quiz natin, ganyan. So, dosing interval is standard. It's every 24 hours. Ang goal natin na pick dito, class, instead na 5 to 10, it's 16 to 24 micrograms per ml. Then, ang goal semen natin is less than 1. Now, for amikacin, okay, for amikacin, it's 15 milligrams per kilogram. For patients with creatinine clearance greater than 80 ml per minute, same, dosing natin is every 24 hours. Ang peak is 56 to 64. Ang goal na semen is less than 1 microgram pa rin. Now, please take note of this one, class. Patient's actual body weight will be used for the computation. Okay, if we're doing extended dosing interval. Okay, so unless the actual body weight is 30% higher than the ideal body weight, then the adjusted body weight will be used. Next method, class, is method 2. Ginagamit din naman to. Ito naman yung madalas na ginagamit, class, for patients with declining renal function. So, standard is method 1. Basta greater than 80. Pero pag less than 80 na yan, say, for example, talagang tawag dito, may significant damage na yung kanyang kidneys, then, class, depende sa creatinine clearance ng patient natin, okay, yung ating magiging dosing. So, again, class, it's still based on kilogram body weight. Right? So, kung 80 to 60, 59, no? Ito lang titingnan nyo, class, oh. Pagdating dito, instead na every 24 hours, every 48 hours na. na kung significantly damage ang kidneys ng patient natin at kailangan niya talaga ng aminoglycosides, every 72 hours na ang dosing natin. So, are we clear? Now, for patients receiving dialysis, these doses should be administered after dialysis. Okay? Ito yung mga dose for patients with dialysis. Normally, kasi pag nagda-dialysis ka, most likely less than 10 ml per minute na ang GFR mo. Right? Okay. So, method 1, method 2. Ang sa ginagamit. This method is designed to ensure that the patient achieves drug-free intervals to prevent development of resistance. So, dose for tobramycin gentamicin is 5.7 per milligram per kilogram, followed by measuring 2 random plasma concentrations. Okay. A satisfactory clearance is a C-mean of less than 1. If C-mean is more than 1, patient-specific PK calculation should be performed to ensure optimal dosing interval, resulting in a trough of less than 1 microgram per ml. Method 3 naman, class, madalang gamitin. Usually, nire-require ko lang sa inyo is method 1 and 2. Either of the two lang naman. Kasi method 1 is greater than 80. Pag nag-less than 18 ml per ang kanyang ml per minute ang kanyang creatinine clearance, then we start using method 2. Method 3, initiate therapy with 3 milligrams per kilogram gentamicin or 15 milligram per kilogram for amikacin. Then serum level drawn for the first 3 days, then every 3 days after. So ang goal natin dito is, the peak concentrations are taken after infusion and mean concentrations are taken 8 to 16 hours. And then get specific pharmacokinetics to adjust dose interval. For gentamicin and tobramycin, ang target na Cmax is 20. For amikacin, it's 60. And desired C-mean for both is less than 1. So high dose of gentamicin and tobramycin takes up 2 hours to distribute. So getting plasma concentration before 2 hours may provide an erroneous estimation. Intermediate or low doses distributes after 1 hour. So let's have here, class, a sample study for that would require extended interval dosing for aminoglycoside. So walang Excel sheet dito. Kasi makita naman, i-multiply nyo lang naman sa actual body weight. Not unless the actual body weight is 30% higher than the ideal body weight, then we use adjusted body weight. Okay, a 60-year-old male patient, BL, has cellulitis of his right lower leg and is admitted to the hospital for IV antibiotic therapy. Other pertinent data includes height of 6 feet, weight of 75 kilograms, serum creatinine of 1.02 milligram per deciliter. WBC count is 16,000 per cubic millimeter, with 78% neutrophils and 8% bands. He has a temperature of 100 degrees Fahrenheit. So using method 1, recommend a dose of tobramycin to be given as extended interval dose for patient PL. Right? So obviously, class, okay, ang lalabas lang dyan would be 382.5. So for method 1, this is gentamicin, our patient is 75 kilograms. Okay? So if we compute, most likely ito naman yun eh. Okay? So 5.1 times 75 kilograms, right? This is 5.1 milligram times 75. And you get 382.5 milligrams. Okay, or approximately 380 milligrams. Q24. Okay, peak and trough concentrations are drawn on BL and reported by the lab as 17 and 1.2 micrograms per ml respectively. Does BL tobramycin to be adjusted? Okay, so obviously, class, in this case, it's greater than 1. Diba, ang goal natin, class, should be less than 1. And a trough concentration of less than 1. So hindi maganda yung 1.2. So therefore, class, we have to adjust. You can actually just compute for this. Okay? Now, assuming that the peak is 17 and the desired C-mean is 0.5, right? Then you can compute for this as ln, 17 minus ln, 0.5 over ang dosing interval mo kung ano man yun, 24 minus 1 hour. And you get a K class of, try nga natin, 0.115. ln 17 minus ln, and then 14. 14 minus ln 0.5 divided by 23, you get 0.1533 sa akin. Ba't kaya 1.115 to? Wait. Joke. ln 17 minus ln 0.5 divided by 24 pala. Ayan din. ln 17 minus ln 0.5 3.5 by 24. Hindi pa rin. 0.146 ako. Ako kabot na compute. Basta 0.115 yan. Sure. Wait. Okay, so we have a peak of 17 and the desired Cmin is 0.5. Tapos ang ating dosing regimen every 24 hours. Infusion time is 1. Oh, sorry. Kaya naman pala. Desired is 0.5 pero actual ko nga pala is 1.2. Kaya naman pala hindi ko makuha-kuha. 1.2 ln 17 minus ln 1.2 kasi I need to get actual K. 2.6. Wait lang. 2.6508 divided by 24 to 423. 2.6508 divided by 23. Yep, 23 nga. 0.1153 per hour. So that's the actual K. So when you compute for dosing interval, just use again the formula that we've mentioned a while ago. Lalabas dyan class will be 31.6 approximately every half day. 1.5 day. Okay? Next one. How do we compute for pediatric population between 1 year old ng baby? Kasi usually pag neonatal, extended tayo. Okay? Or 7 years old, up to 17 years old. Okay. Normally, class, we avoid aminoglycosides in children with impaired renal functions or those on multiple concomitant nephrotoxins. Now, the conventional dosing is every 8 hours. It's more commonly used for pediatric population. Okay. Those that are greater than 30 days old, then extended extended interval. Extended interval Q24 aminoglycoside dosing is preferred in cystic fibrosis patients, okay, who are more than 3 years old. Okay, and then doses can be given over 30 minutes. So pwede tayong infuse 30 minutes. Okay. So peak serum concentrations are important for bactericidal killing. Trough serum concentration monitoring is recommended as a safety marker. So should be checked at least once weekly for pediatric population. On aminoglycoside therapy for 30 minutes prior to a dose. Now, class, just so you know, but what is cystic fibrosis? I forget. So, balik kasi cystic fibrosis is a genetic disorder. It usually causes severe lung damage, okay, to the lung damage, digestive system, and other organs of the body. Cystic fibrosis can cause excessive production of mucus in the lungs, causing difficulty in breathing and making patients more prone to infections. So, hence, if you're infected, normally, class, especially if it's due to cystic fibrosis, then one of the drug of choice would be aminoglycosides. Okay? Okay. So necessary patient information for dosing, for body weight. Use actual body weight unless, again, actual body weight is 30% higher than the ideal body weight. Then we'll be using adjusted body weight. So IBW calculation for children between 1 to 17 years old says height times 2. Okay, times 1.65. Ano yan? Height lang to. Ako ba nakuha yung mga yan? Okay, that's height times 1.65 divided by 1,000. Okay, and then adjusted body weight is pretty much the same. IBW times 0.4, actual body weight minus ideal body weight. Then for creatinine clearance, okay, so usually given na rin naman yung K natin here. Length ng patient mo, right, in centimeters. Okay, times K. Right, yung K na yung class depends on the age of the patient divided by your serum creatinine. Okay, and that will be yun yung makuha mong creatinine clearance. Especially class, applicable ito sa mga babies. Okay, so length niya in centimeters. and then multiply to your K. So for infants, it's 1 to 52 weeks old, 0.45. 1 to 13 years old, 0.55. Okay, adolescent females, 13 to 16, 0.55. Then 0.7 for males, 13 to 16 years old. So dito lang nagkakatalo yun pagdating sa adolescents. Right? Then length nila class should be in centimeters divided by their serum creatinine. Now for neonatal dosing, so this one is used for all infants greater than 30 days old. Okay? Corrected gestational age, usually mention, huwag kayo mag-alala, si pedia na magsasabi nito. Okay? Or si pedia ba o si OB? Not really sure. Pero kung sakali ka sa cases natin, given na to, corrected gestational age ng natin, ng patient natin. Okay? And then here class, yung postnatal natal age in terms of days. Okay, so 0 to 7 days, 8 to 24, greater than 29 days. Andito lang yung mga dose nila and the given dosing intervals. Okay? Okay. So here naman is a general dosing recommendation for gentamicin and tobramycin. So conventional dosing, basta ang age is greater than 30 days old, starting dose will be 2.5 mg per kilogram per dose every 8 hours. Higher dose may be utilized in young infants or children. If aminoglycoside is necessary and creatinine clearance is less than 30, you may start on Q12. Okay? Or kung extended interval dosing, as long as the patient is non-CF, walang cystic fibrosis. Okay? Kung 3 to 6 months, 3 months to less than 2 years, it's 9.5 mg per kilogram. Okay? Then the dosing is every 24 hours. Pag less than 8 years, 8.5 naman. And greater than 8 years, it's 7 every 24 hours. Excuse me. Now, kung may UTI naman ng patient natin, again, for gentamicin to here's the conventional dosing and here's for the extended interval dosing. Okay? Now, for cystic fibrosis or may pulmonary infection, normally class, if that's the case, tobramycin ang ibibigay natin sa patient natin. So, conventional dosing, okay, for children less than 3 years old is 3.3 milligrams per kilogram every 8 hours. Kung mag-extended interval tayo, say for example, may problem ng kidneys ng patient natin, okay, pero usually, pag may cystic fibrosis, ito na yung gagamitin natin. Extended interval. Okay, 10 to 15 milligrams per kilogram for every 24 hours. And alternative dosing would be 7.5 to 10. Every 12 hours naman. May be utilized in patients with cystic fibrosis with ultra-rapid renal clearance. Ito yung masyadong mataas yung kanilang nag-hyperfiltration sila. Okay? Okay, so what about for therapeutic drug monitoring? Ang desired peak natin for, of course, tobramycin and gentamicin is between 6 to 10. Drops less than 2. Drawn on the 4th dose. Okay, for extended interval dosing naman, non-CF patient, meaning non-cystic fibrosis. Desired peaks is between 12 to 20. Okay, then the desired trough is less than 5. Then kung may cystic fibrosis naman ng patient natin, desired peaks would be 20 to 40. Again, still, trough should be less than 5. Okay? An alternative dosing would be, kung basta gumamit ka ng Q12 for CF patients, for patients with cystic fibrosis, the desired peak should be greater than 10, but the trough should be less than 1. Right? Okay, so that's pretty much class, the end of the topic for today regarding aminoglycosides. So please try to understand. Okay, ang pinakagusto ko talaga dito class na maintindihan ninyo is kailan ko gagamitin yung mga dosing regimens na designed for individual patients. Yun ang kailangan kong maunawaan nyo dito. Kasi class, ang quizzes natin dito ay open notes naman lahat. Okay, I'm giving you the liberty to open your notes. But the judgment class is something that I want you to do on your own. Dapat ma-determine nyo just to apply your critical thinking class. Okay, using the guidelines that we have right now. Right? And so with that, thank you very much. And I'll see you guys next time. Bye, everyone.